star clock, and I'm going to mute the lines, mute everybody's lines, and then we're going to get started.
The conference has been muted.
Okay, so welcome to Oral Care Approaches when Residents Have Expressive Behaviors. Our presenters today are Jessica Toma. Unfortunately, Kim Krusczynski is ill today and unable to speak, so Sue Bailey has kindly agreed to take her place. I'm going to be your facilitator. I'm Heather Woodbeck, and I'm the Best Practice Coordinator for the Northwest LHIN. Sue Bailey has helped a lot in the working on the presentations with Kim and Jessica, and has kindly agreed to step in. So she is the, Sue, Central East, I think, Best Practice Coordinator. Sorry, Sue. Anyway, and my oral care colleague, Central, just Central, plain Central, thank you. Best Practice Coordinator. My colleague for the oral care community of practice is Ebo McDonald, and Ebo is the Best Practice Coordinator for the Champlain LHIN. So for those of you that are new to this webinar technology, there's this little arrow, set of double arrows up here, can put your screen to a full screen. If you have questions later on or during the event, please use the Q&A panel where you just type in your questions, and Ebo is on standby and will respond to your questions. We'll also ask you at the end of it to unmute your line by pressing *7. So our objectives for today are to describe the key considerations for doing oral care for residents who have responsive, or the newest term is expressive behaviors, share successful strategies that a long-term care home has used with residents who have expressive behaviors, and also share some strategies from the psychogeriatric resource consultant. Also share participant tips and takeaways, what things have worked for you, or what are you going to take away that might work. So these are some of the communication principles for oral care. First off, you need to know your resident and consider the resident's beliefs, values, et cetera. Ask about previous oral care practices. And an example of this is one of the homes had a resident who hadn't done oral care and for their whole life, and the family said to the long-term care home, well, why are you trying to brush your teeth? She's never gone to the dentist or cared about having a clean mouth. So what that home was able to do was put that into the care plan. So yes, they do offer to do oral care, but if the resident refuses, they're honoring her previous oral care practices. When working directly with the resident, try to establish a positive connection, approach from up front if you can, make so they know that you're in the room with them, use eye contact, smile, explain what you're doing, and try to talk throughout. Be gentle, touch their cheek, be really gentle inside their mouth in case there's areas of soreness, and then encourage the residents to do as much as they can by demonstrating, by using hand over hand, putting your hand over their hand or your hand under their hand. Can all be useful. We have this lovely one-page sheet that Evo and her master's student, I believe, developed, and this just summarizes all the ideas for how to prevent responsive and expressive behaviors during oral care. The first column talks about preparing for oral care, some of the things that I mentioned already, establishing trust, try to make sure the residents relax, try to turn off distractive noises if you can, and then set things up, make sure that you got supplies, try to brush the residents' teeth and do their mouth care when the resident prefers. You need to do it twice a day, ideally after they've had breakfast and before bed, so that they get as long as possible with a clean mouth. Then if behaviors start, then look at stop and try it, come back and try again. And then that final column has some really good techniques that you can try along with stop and go, the hand over hand, hand under hand, bridging and distraction. We have a previous webinar that we did last year on best practice approaches for responsive behavior, and it illustrates these techniques even more. So at the end of the presentation, we've put a link to that resource. So as we said earlier, your overall approach is really important. Communication is key. You need to talk about what you're doing, get the resident to help, have the resident to be relaxed and comfortable. As I said, try again later. Really important to share successful approaches and strategies with the team. In one home, I went in and with the dental hygienist, and the hygienist was looking to do an oral assessment, and the resident was sitting on her bed, and she wouldn't cooperate, and then a PSW came along and said, oh, I know how I can get her to cooperate, and brought her into the bathroom. And as soon as she was in the bathroom, that was the cue for her to open her mouth, and that was where she did oral care. So just to make sure you put those successful strategies into your care plan, and so that everybody knows what works best. The best time to do oral care is when the resident wants it, and try to individualize when you can. Just a bit about oral care and responsive behaviors. As you probably know, when resident people have dementia, there's more an up and down of emotion. Dementia affects the ability to reason, to be logical, and to problem solve. And often the emotional brain takes over, and you get this survival of the fight, fright, or even I've heard called fright, flight, or fight response. So those three, residents can do all three of those. And your goal is to have the resident relaxed and agreeable, and not be forcing oral care just because it sets it up for future problems for others. So you want to try to use the DPA, gentle persuasive approach, or the PIECES framework if you're having problems. Other strategies, as I said earlier, make sure they're communicated, have an oral care plan, involve your dental or oral care professionals. Lots of homes, sometimes you have a dental hygienist who will come in and do on-site care. Some dentists will do this, but it's sometimes getting another person's approach can really work. Use GPA and involve the psychogeriatric resource consultant, or BSO, if you have somebody refusing oral care on a long term. Now, I'm just going to pass the ball over to Jessica. It's my pleasure to introduce Jessica Toma. Jessica is Associate Director of Care at Weston Terrace Long-Term Care Home. Okay, here, trying to pass over. There we go. Okay. She's worked with Sienna Senior Living for over 7 years. She's a registered nurse with Bachelor of Science from York University, and she has her CNA Gerontological Nursing certification, which she got in 2016. Jessica's had increasing levels of responsibility with Sienna, so she brings to us a variety of perspectives on the issues of doing oral care. So I'm passing it on to you there, Jessica.
Hello there. Hi, everyone. My name is Jessica Toma. Thank you, Heather. So yes, my name is Jessica Toma. I work as Associate Director of Care at Weston Terrace. So Weston Terrace is a long-term care home with 7 home areas, including 1 specialty unit, which is our secure home area. So we have located in the Toronto's East End, and we're part of Sienna Senior Living. So I'm just going to share my experience with the oral care program, as well as the initiative that we focused on in 2015. So overall, in fall of 2015, we began an initiative on oral care for residents with responsive behaviors. So we had been doing some quality improvement planning, looking to see what initiatives we should be focusing on. When we were meeting with our staff, having our PSW and registered nurses meetings, it did come up that they were having some difficulties finding out a way to manage the expressive or responsive behaviors while they were trying to deliver that care. And one of the things that did come out is that we could use the RNAO toolkit and use the gap analysis to find out just where in the practice we were lacking. So we use the best practice guideline, the oral health assessment and interventions, and then there's also a gap analysis that goes along with that to identify what areas to improve. So with that, we initiated the program by having meetings on our home areas specific to our secure home area. So overall, we held focus groups with the registered staff and PSWs to review the risks and review the challenge groups that is identified. For us, that's going to be our residents with dementia and expressive behavior. So with that being said, we were able to find out from the registered nurses and PSWs working with those specific residents, those individualized cases, to find out where are they having issues, where are they struggling to deliver that care, and where can we, as a team, use best practices to make sure that we're both aligning, so that what's going on the floor is really reflective of the current best practice. So we discussed about what's going on the home area with those individual residents right at the point of care. So is it that someone, isn't wanting to open their mouth? Is it that someone isn't wanting to come into the bathroom? Find out exactly at that point of care where we were lacking. Okay, so some successes we did have. We had success by approaching the residents in their own space and their own time. So when we go to think about oral care, we think, okay, maybe after a meal in the resident's washroom. But realistically, for some residents and specific residents that had responsive behaviors and dementia, that was not working. So what we did is we went into their space, their time, find the best time for that resident where, they're most receptive to the care in the location that is best for them on the home area. So we reviewed with the staff, when are they in a relaxed, more calm mood, and where are they in a more relaxed, calm mood. So, even if we're doing oral care in another room that's not the resident washroom, but we've, used cleanliness, we've gathered all the supplies we need, and we've met the resident at that time. So we would just care plan that so that we would have that if there were to be, a question of why is oral care being performed outside of the resident's room, outside of the washroom, we would have it in the care plan that the resident prefers it at this time in this place on the unit. So that being said, we really built on those strengths, and when we did have successes, it made the staff, the frontline PSWs, registered nurses see that their expertise were being able to be integrated into these best practices. So that was something that was very positive for them. Some challenges, initial implementation. So initially when we first started this initiative, we did find that, certain members of the team were not as receptive as others, but as we continued to, work together and find from each, different departments, different staff members, what we really needed to give the residents the best care, and then we would move from there. So that was an initial challenge, but we did get people on board and really buying in once they saw the successes that we were having. Another challenge is some specific high-risk cases where, the responsive behaviors are not always predictable, perhaps, and with residents with responsive expressive behaviors, we can't always predict, what's going to provoke it, what's going to trigger that, and that was one thing that we did have a bit of a challenge with was for residents who we weren't able to find so much of a pattern. So that being said, I feel that by integrating the best practice guideline into the everyday practice, it's really solidifying what's going on the front lines, what's going on in long-term care, and we were able to use that best practice guideline to ensure that we're aligning our practice. So I just wanted to thank Sue Bailey for all of her assistance with the program in the home, and thank RNAO for continuing to provide the best practice guidelines to ensure that our practice aligns with the most current research and the best practices. So thank you so much for the opportunity today.
Well, thank you, Jessica. That was good.
Thanks, Jessica. Terrific work.
Okay, back to being the presenter. So I'm going to advance the slides for you. So it's my pleasure to introduce Sue Bailey. This isn't Sue, this is Kim, who's ill today. So Sue Bailey has been best practice coordinator for about 8 years, right?
7 years.
7 years, okay. Yeah. And before that, she was a psychogeriatric resource consultant, so she brings this broad background and a really good understanding of behaviors. So I'm going to turn it over to you, Sue.
Okay, thank you very much, Heather, and it's a pleasure to be here. Although Kim is not able to be with us today, we did communicate quite a bit to work on this presentation. So unfortunately, she has bronchitis. She can't even talk. But Kim is an RN, BSCN, through Ryerson, and she is a psychogeriatric resource consultant through the Scarborough Hospital. Kim also was a panel member on our best practice guideline for delirium, dementia, and depression in older adults. And she says that it would be quite common for to get a referral from a home regarding a resident who is uncomfortable with oral care, either due to pain or just the physical closeness of having a staff member there and not understanding what it's about. So I'm going to read out what Kim has forwarded to me today. Oral care is a key factor in the resident's overall health and well-being, so being able to complete this task is important. However, delivering oral care is rarely an emergency, so take the time to plan how you will approach the resident and the task. One important step is to assess for any problems in the mouth or any pain that may be present. Are we aware of any loss of teeth? Do the dentures fit properly? Can the family tell you anything about the resident's habits and history of dental issues? Many of you will be familiar with the gentle persuasive approach, or GPA, stop-and-go technique. And this is just an approach to, take your time. Maybe if you're really close to the resident, step back for a little breathing period just to give them a break. And this helps us to remember that connecting with the resident is key to any task if the person has responsive behaviors. Make eye contact, have a positive facial expression, and be relaxed yourself. Residents can pick up on nonverbal communication. You may have to explain in short sentences or phrases, giving the person plenty of time to understand what you are trying to do for them. Using visual cues is important, such as showing them a toothbrush and the toothpaste. That is a good cue as to what you're asking them to do. Communication is key. We want to try and make the experience as pleasant as possible, so think about when your resident is at their best during the day. What flavor of toothpaste do they like? Can you play relaxing music or sing in the room or bathroom? Again, using a pleasant and positive approach may help reduce any tension or anxiety around this task. And remember, you are part of a team who is there to help. Is the BSO, Behaviour Support Ontario team, involved? And are there activities that provide a distraction for this person? giving them something to hold, maybe a rolled up cloth or an extra toothbrush. Consult your PRC for support and coaching. Use the other integrated health team people, such as a nurse practitioner if you have one, a nurse-led outreach team, or others involved in care. This may be a task that takes time to fully complete. It may take several tries as you and the resident get to know what works and what does not. It's not a failure if it doesn't get completed in the first try. The important thing is never to give up. And lastly, focus on the person and not the task. And I just want to let you know that in 2016, Kim did a presentation for the oral care community of practice, which has been archived and is available for you to listen to and see the slides in more detail. So that was what Kim forwarded to me, and I know, Heather, you have the stop and go technique up. I wasn't sure if you're going to be talking more about that, or do you want me to go through it?
I put it up for you there.
Okay, so for those of you that haven't taken the GPA, it's strongly recommended. It's evaluated very highly for success, and stop and go is part of this. It's a foundational technique for building trust. And now we've lost the slide. So here we go. So stop. When there's signs of responsive or expressive behaviors arise as you're doing oral care, stop, take maybe a half a step back to give more space, validate the resident's feelings, emotion, or pain, get feedback from the resident. How's it going? Continually explain step by step as you go along. Keep a positive and respectful attitude. Remember that cognitively impaired residents may perceive emotions better than they understand words, so they're really focused on how you're coming across. Then go, try again. Stop and go may be required a few times throughout the process. And that's it from me. So back to you, Heather. Thank you.
Thank you, Sue, for sharing with the information from Kim.
You're welcome.
Okay, I'm going to just skip over the next one. So now we want to have you who are participating to share some of your tips and takeaways that might work, things that you've found work well. So you can type those into the question and answer box on the right lower side of your screen, or you can unmute your phone by pressing *7. I'm not hearing any tips or seeing anything coming through here.
It's Sue. I'm just going to say that actually it's been several years ago now, but one thing that I did in one of the homes is I met with all the staff, nurses, PSWs, and just to talk about their oral care beliefs, and it was quite interesting, the range. Like, you know, usually I just thought everybody did their oral care the way I do and at the times of day that I do, and I was quite surprised at how many variations there are. And that was so important for the whole room of staff to understand, because it helps us realize the variation with our residents as well, and how just assuming everybody does it our way can lead to responsive behaviors.
Just to pick up a little bit of what Sue was saying, it's EBO. I remember when I worked in long-term care, there was a resident who would, and I would hear her because I happened to just be going down the hall doing meds, and I would hear her yelling, no, 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 no. And I went in one day to see what was going on, and it was just the way that the PSW was approaching her. And I said, well, have you tried actually taking an extra toothbrush and showing her what you're doing? And so she did take another toothbrush, went down in front of her, was explaining what she was doing, was showing sort of to to brush the teeth, and then used her hand to guide the resident's hand with the toothbrush in it, having her own toothbrush into her mouth, and then she started brushing on her own. And so just sometimes having teamwork and working together as a team, like Jessica was talking about, is really important to find strategies that are going to work.
Yeah, and just to follow up on the idea of how we each do our own oral care, that's really pretty important. Some homes have found that they actually needed to start talking first about how the staff did their own oral care, because people have different approaches. I know we did a mini survey in one oral care team I was with, and I said, oh, I would never go to bed without brushing my teeth. It just makes me, I just said, well, I personally hate that feeling. And someone else said, well, I never brush my teeth. I always, I don't mind that. I brush them when I get up in the morning. And so those kind of issues affect how the kind of oral care we do with ourselves affects the kind of oral care we think is important to provide to residents and to patients.
So I have a question here. As in a slide summarizing techniques, it mentioned using a dampened 4x4 piece of gauze. Can we elaborate? So I can
yes.
talk one.
Okay, you talk to that.
Yep. So this technique is just another way of getting into the mouth if they won't let you put a toothbrush in, where you just take a 4x4 gauze, dampen it, wrap it around your finger, and use it to just sweep the debris that's in the pockets and the cheeks out. So it's just so it can get the stuff out of the mouth that might be sitting there, because residents have a hard time when you age. You get a hard time really maneuvering your tongue around and in your mouth.
You can also do a little bit on the outsides of the teeth with that roughened gauze. You just have to, the risk of it is that you could get bitten, so you don't want to be bitten. But it is a pretty effective way of removing sort of gunk from the outside of the teeth, eh?
Yep. Don't see any other questions.
It's Sue again. I just wanted to say that one resident with she was kind of at end of life with dementia, and she stopped eating very much. Like over a few weeks, she gradually got to just having, sips. And it was just assumed it was because it's the end of her life. But when she was just, an hour away from dying, she was breathing heavily with her mouth open, and it was discovered that she had all kinds of sores in her mouth. And the staff felt bad because, they didn't think to look in her mouth when she stopped eating to see if there was anything wrong with her oral cavity.
Yeah, I think that's important to assess people's mouths when they stop eating. I think that's a really sort of sad, very sad, but it really illustrates the point, how important an oral cavity assessment is. So if we don't have any other questions or sharing of your tips, I'm just going to carry on then with the resources. There's a bunch of excellent resources in oral care. The first one we want to point you to is the Best Practice Toolkit. We have, I think, pretty close to 100 resources there. You can see here we've got the best practice bloggers that are up there. We've got approaches to oral care and algorithms, and the best practice guideline, which is next on our list here. The guidelines available, anybody can download these, and they've got the appendices are quite good to look at as well. There's lots of helpful resources in the appendices. The other resource that I'm going to draw your attention to is the one that Sue mentioned earlier that Kim was on the development panel for. The delirium, dementia, and depression in older adults is a new or a revised best practice guideline that came out last year. It's a combination of the assessment guideline and the caregiving strategies guideline for dealing with delirium, dementia, and depression. It's got lots of good approaches, again, for people who might be resisting oral care. This next tool here, approaches for oral care interventions for residents with responsive behaviors, communication, or functional impairments. This is done about 2008 or so, and it's got some, again, really good ideas for how to approach people and to keep trying and to different ideas to try. And then we have, this is our webinar that we did last year. You can go onto YouTube if you search for oral care and responsive behaviors. It will pop right up there. I forgot to see how many hits we've gotten on it. But the pocket dockets that have been done a few years ago by the Oral Care Collaborative, again, are quite useful. They're on the website. Looking at different approaches, they discuss different approaches for giving oral care. The GPA, you can find more information on gentle persuasive approaches on their website here. And then on the PIECES website, they have more information on that approach. And of course, your psychogeriatric resource consultant or behavioral support program can help you with that. This Government of South Australia has done a phenomenal resource on better oral care and residential care. They don't call it long-term care, they call it residential care. It's just an excellent resource with detailed pictures. It has things on oral assessment and shows you all the different kinds of conditions that you can find in residents' mouths. It's just a beautifully done resource. Now, we have some upcoming webinars that could be useful to you. Next week, our colleagues are going to be presenting interprofessional collaborative practice among nurses. This is the newest section of our long-term care resource toolkit. So this is working with other healthcare providers like dental hygienists, dentists, how you can maximize their contributions to your team. Then coming up in 2 more weeks, we've got denture details, labeling, fit, and other issues with denturist Amanda Boyle. Dentures are a huge issue in long-term care, and so trying to get a handle on them, particularly with labeling and looking at things like fit and how that can be improved is fairly important. So we invite you to join us for that webinar. Then does anyone have any final questions? And you'll notice Ibo's put the poll up at the right, so if you could fill in the poll, that would be good because that will give us feedback. I'm not seeing any questions or hearing any questions. I always like to wait a few minutes just because mute and unmute can be a pain. But if there's no questions, then I'm going to draw this to a close and say thank you for your participation. And thank you to Jessica and Sue for taking the time to share their knowledge with us. Oral care is a really important part of care, and as Sue illustrated with her example, sometimes if things get missed, it has very negative consequences for our residents. So thank you for your participation today.
Thank you.
Thank you so much, Heather.
Bye.
You're welcome. Bye-bye.
Bye.